All right, let's talk about pleural effusions. You're going to see these all the time on the wards, but really understanding the why behind the fluid is what separates guessing from true clinical reasoning. In this explainer, we are going to break down everything you need to know, from the basic science to treatment in a super high-yield way for your rotations and, of course, for your exams.
Okay, so here's our game plan. We're going to build this from the ground up. We'll start with the foundational science, then walk through how a patient presents, how to diagnose it, how to analyze the fluid, which is key, and finally how to treat it. So let's kick things off with the science.
All right, Section 1, Foundational Science. We're really going to focus on understanding the why behind the fluid. Honestly, if you can nail this part, everything else just clicks into place.
So what is a pleural effusion at its most basic level? It's simply an abnormal buildup of fluid in the pleural space, that potential space between the lung and the chest wall. Normally, you've got just a tiny bit of fluid in there, maybe 5 to 15 milliliters, that acts like a lubricant. An effusion happens when that delicate balance gets thrown off, and fluid starts building up faster than it can be cleared away.
So how does that imbalance happen? Well, it all comes down to Starling's forces. The easiest way to think about this is like a constant tug of war. You've got hydrostatic pressure, which is the push that forces fluid out of the capillaries, and then you have oncotic pressure, which is the pull from proteins like albumin that draws fluid back in. A pleural effusion is what happens when that tug of war goes wrong. Either the push gets way too strong or the pull gets way too weak. And you can trace that imbalance back to one of these 6 main mechanisms. For example, congestive heart failure is a classic case of too much push. It jacks up the hydrostatic pressure. Pneumonia, on the other hand, can make the capillaries leaky, and something like a malignancy could literally block the lymphatic drains. You see? Different paths, but they all lead to the same result: fluid getting trapped in the pleural space.
Okay, so we've got the why covered. Now let's move on to the what. Section 2, the patient presentation. How are you actually going to recognize this when a patient walks in?
The number one thing patients are going to complain about is dyspnea, or shortness of breath. And it makes perfect sense, right? You've got all this fluid literally squishing the lung so it can't fully expand. If the lining of the lung, the pleura, is inflamed, they might also describe a really sharp, stabbing chest pain that gets worse when they take a deep breath. That's a huge clue.
Now for the physical exam, these are the classic findings. Just think of that fluid as a big sound-dampening barrier. So when you feel the chest and have the patient say 99, the vibrations will feel weaker. That's your decreased tactile fremitus. When you tap on their back, instead of a hollow, resonant sound, you'll hear a stony, dull thud. And when you listen with your stethoscope, the breath sounds will be muffled or maybe even absent altogether. So your history and physical exam are pointing strongly towards an effusion. What's the next move? That brings us to Section 3, the diagnostic pathway. Let's look at the steps to go from just suspecting it to actually confirming it. Your first step is imaging, and that's usually a chest X-ray. You're looking for that classic sign, blunting of the costophrenic angle, where that sharp corner at the bottom of the lung just disappears. If you see that, or confirm a fluid layer of more than 10 millimeters, then it's time for the next step, a diagnostic thoracentesis, to get a sample of that fluid. Okay, you've got the fluid. Now the real detective work starts. This is Section 4, the crucial analysis. Honestly, analyzing this fluid is the key that unlocks the entire diagnosis.
And everything hinges on this one fundamental question. Is this fluid a transudate or is it an exudate? Getting this right is everything. It's the fork in the road that's going to guide your whole investigation and dramatically narrow down what could be causing the problem.
To figure that out, we use Light's criteria. You absolutely have to know this for your exams. It's non-negotiable. And the rule is simple. If the fluid meets just one of these 3 criteria for protein and LDH, it is an exudate. If it meets none of them, it's a transudate. That's it. And here's why that distinction is so powerful. Transudates are usually caused by systemic whole-body problems. Think heart failure, cirrhosis, kidney disease. It's a pressure problem. Exudates, on the other hand, point to a local issue. Something is wrong right there in the chest. Inflammation or disease, like pneumonia, cancer, or TB. So let's say Light's criteria tell you it's an exudate. Now you have to dig deeper, and you need to pay very close attention to the pH. A pleural fluid pH below 7.2 is a major red flag, especially if you suspect pneumonia. It's telling you this is a complicated effusion and it's probably not going to resolve on its own. It needs to be drained. Next, you'll look at the glucose level. If the glucose in the fluid is low, you got to ask, what's eating all the sugar? And there are a few main culprits. It could be bacteria from an infection, rapidly dividing cancer cells, or the intense inflammation you'd see in something like rheumatoid arthritis. A low glucose tells you something is very metabolically active in there.
The cell count gives you another fantastic clue, especially about timing. If you see a ton of neutrophils, you should be thinking about an acute process, like a bacterial infection. But if you see mostly lymphocytes, your brain should immediately shift gears to more chronic problems, like tuberculosis or malignancy. It's a super useful distinction.
All right, let's bring it all home with our final section. Section 5, the treatment strategy. We've done the workup, we have a good idea what's going on, so now what do we actually do? The key is always to treat the underlying cause, not just the fluid.
This table is a great high-yield summary. You can see how the treatment flows directly from the cause. For a transudate from heart failure, you use diuretics like furosemide to get fluid off the entire body. For an exudate from pneumonia, you treat the infection with antibiotics. And for an empyema, that's pus, antibiotics alone aren't enough. You have to physically drain that pus with a chest tube.
So, after all of that, what's the one clinical pearl you absolutely cannot forget? If you remember only one thing, let it be this. In a patient with pneumonia, a pleural fluid pH of less than 7.2 is a critical sign. It means that effusion is complicated and it is highly unlikely to resolve without drainage. Making that call and making it quickly is one of the most important decisions you'll make for that patient.